Can everyone turn their mics on?
Good morning.
Hello again. How are you?
I'm great.
Okay, just want to make sure we have good sound. And we have a few more people connecting.
Sure. Leslie, we have a couple of more minutes. It's 9:58, or sorry, 8:58. So we'll see.
Yeah, we're still waiting for people to connect here.
Yep.
Don't have a quorum yet. Oh, Bocon is here. We're having some people having difficulty signing in. Nope, there we have Commissioner Grady. Chair, we can get started whenever you would like to call the meeting to order.
Okay, that's good. We start off the call. It's about couple of minutes over 9. So I'll call the meeting to order. And the first item on the agenda really is, before I get to the roll call, we have received the resignation of Dr. Slonim. So that just FYI for everybody. Leslie, did we get a resignation or notification?
We received a copy of the resignation from the governor's office.
Okay, fine.
He had sent it to the governor's office.
Right. So FYI for everybody, he had some very valuable contributions to this commission, and some of his input, passionate input on his causes will be missed. So having said that, the next item on the agenda is approval of the February 16th minutes.
A roll call first, Chair Khan.
Sorry, that's right, a roll call. Go ahead, Leslie.
Okay. Babette Bond is excused today, but she's trying to log in right now because she has a break in her schedule. She's traveling, so hopefully she'll be able to join us. But we have Commissioner Lenitra Grady.
Good morning, present.
Good morning. And Flo Khan.
Good morning, and I'm present as well. And just to note, I too, unfortunately, will have to miss a portion of today's meeting due to travel. So I'll stay on as long as I can.
Thank you, Commissioner. Chair Khan,
Present.
Commissioner Leanne McAllister,
Present.
Commissioner Yarleni Roa-Dugan,
Present.
Vice Chair Sandy Rubelit,
Present.
Commissioner Beth Slamowitz is absent and excused today. Commissioner Tiffany Tyler Garner.
Present.
Commissioner Mason Van Howling. I see you there, Mason. Can you unmute? I don't know if he's having technical difficulties or not, but I see him on the screen. Commissioner Tyler Winkler.
Present.
And then we'll go to our non-voting members. We have Laura Rich,
I am here.
Barbara Richardson.
Here.
Richard Whitley.
Present.
And then we have Janelle Davis, who is going to be representing Silver State Health Exchange when she connects. So, Mr. Chair, we do have a quorum.
Thank you, Leslie. Now that we have a quorum, we go to the item on the agenda for possible action for approval of minutes from February 16th. I presume everybody got a copy of the minutes, and I'm presuming that everybody had a chance to review them. Are there any changes, modifications, different recollections that anybody has on the minutes as sent out to everybody? Hearing none, any opposed to the approval of minutes? Hearing none, so the minutes stand approved.
Can we have a motion? Can we have a motion to approve the minutes, please?
We
I'll
can
make
do
a
that.
motion.
Motion to approve.
Who made the motion?
Sandy,
Oh, thank you, Sandy.
sure.
Is there a second?
I second Tyler Winkler.
All those in favor?
Aye.
Aye.
Any opposed?
Aye.
Thank you. So, moving on to the next item on the agenda is a public comment. Leslie, do we have anybody up north or south in person or written input?
I do not have any. Is anyone that is an attendee wanting to make a public comment? If you're on the phone call, you would just hit *9 to raise your hand. I'm not seeing anybody, Chair.
Okay, thank you. See, move on to the next item on the agenda is a discussion and overview of bill draft request proposal process, including possible topics. Sandy, you want to take that on?
Sure. Thanks, Chair. Good morning, everyone. We just wanted to take a moment to go over this process, especially for the new commissioners. This is the process that Sarah used last session. And so we do have the opportunity to recommend 3 bill drafts to the governor. And so last session, we only recommended 2 because we didn't really have enough time. So we wanted to start earlier this time around. So the process that we use, Leslie sent out a template. And so it has the 19 areas that the commission has oversight of. And so the bills that we recommend should fall into one of those categories. It looks like Tyler has his hand raised.
Yes, he does.
Sorry, and I guess one of the deputy attorney generals answered this for us, but my understanding is that statutorily we're empowered to submit 3 BDRs to the LCB directly. It's not a recommendation to the governor.
Okay.
I just want to make sure that's correct.
If the deputy attorney general said that, then I would assume it's correct. So,
Okay, good. Thank you.
yeah. Okay, so while we're on questions, does anyone have any questions in general about the process before we go into any of the topics that were preliminarily submitted?
So everybody received the information regarding the topics and the template, as Sandy mentioned, of the top priorities and whatever the majority was for the top 3. In the past, we selected the top 2. So that's the process we had followed and worked very well. Go ahead, Sandy.
Tyler, you have a question?
Yes, I was wondering if there would be like a form or something that we'd fill out to pick our priorities, or will we just discuss it here?
So this is just to open the conversation. This is not the end of the conversation. It's just the beginning. Several commissioners did not have an opportunity to yet submit their recommendations. So the form of the template at the top, and if it's helpful, I can share my screen to show everyone while we talk about it. So let me try that right now. Okay. Can everyone see my screen? Is it displaying, Leslie?
Yes,
Yes.
I'm sorry. Yes, I can see it.
Thanks. Thank you. So if you can see this top grid, this is how it was organized by topic area. So, the more bill recommendations in a certain topic area kind of floats that one to the top. We have not gotten to the point where commissioners have prioritized or any of that. This is just really opening the conversation up and throwing the ideas out there. So, so this is what we used last time that kind of was a tool to get us to the point where we could see where the most interest was in a particular topic area. It looks like Commissioner Bond has her hand raised.
Oh, sorry, thank you. I just wanted to clarify something Dr. Khan said, which is that last time, maybe I missed it, I'm late, that we used 2, but we actually have 3 bill drafts, and I think it would be hopeful that we can use all 3 of them this time. So I just want to make sure I didn't misunderstand something. Thank you.
No,
Yes.
you're right, Babette. What happened, as Sandy mentioned earlier, because of the time constraints last time, we were given a short time period, so we ended up with 2. But you're right, 3, if we can get to it. We have time this time.
Okay, thank you.
Okay, do we have any other questions?
I thought that we were all supposed to have them done, so what will, I'm not sure what
Let me
the
catch.
opportunity is going to be now. Thank you.
Yeah. So many commissioners did not get their recommendations in before this meeting. So we just wanted to use this as a discussion item. We won't be voting or anything like that. It's just kind of opening conversation, orienting everyone to the process, answering any questions for new commissioners that weren't here the last go round. So this might be a short conversation. It might be, we've allotted an hour. I don't think it'll take that long. If we want to go through the ones that were submitted, we can certainly do that. But this is not the end of the recommendations by any means.
Thank you.
Sure. Okay.
So we go over the chart that the top three that we got by, when we say top three, most commissioners submitted the similar items amongst the top three.
So we
Can
haven't.
you for them?
Actually, Chair Kwan, we haven't prioritized yet. We just really have accepted everyone's ideas as is, because we did only get, I think, 4 commissioners submitting ideas. So we wanted to open it up for a little bit longer to allow more commissioners some more time to potentially submit some bill recommendations. So it looks like we have some more questions. Commissioner Tyler Gardner.
Good morning. Thank you for the opportunity to inquire. I, as someone new to the process, I had a few questions about it, and one of them is there an expectation that each commissioner submit at least one suggested BDR as a part of the process? I wasn't clear about that. And so I hear you saying that you only receive recommendations from 4 of the members. I think some of the challenge may have been.
Tyler, you're breaking up. Tyler, you're breaking up your voice unless others can hear him. For me, it's breaking up.
Are you able to hear me now? Just a quick question.
Go ahead.
Is everyone expected to submit a BDR, a recommended BDR?
I wouldn't say it's expected. A lot of times another commissioner might submit the same idea that you had, and you can maybe collaborate on a bill. But it is an opportunity for us to collectively submit 3, and we want to make sure we get all 3 this go around.
Thank you.
Sure. Commissioner Winkler.
And so before I go to my first point, I would definitely want to hear from everyone what their suggestions would want to be, especially because we've collected such a great group to serve on the board, has a lot of great expertise in this area. But perhaps we should set a hard deadline before we say, okay, this is what we have. But I did want to say one of the something I was very interested in, since now we maybe have a little bit more time, is talking with the other committees and boards who also have the ability to submit bills, to make sure we're not duplicating anything, or to hear what they have to say. I know like the behavioral health policy boards, they're able to submit something. There's a few other boards underneath the department. I don't know how far along they are in the process, but it would be great to hear from them. Yeah.
Okay, thank you. Okay, so if everyone is agreeable, we can have each commissioner just briefly describe their submissions that have been submitted. And we'd like to keep it as close to 5 minutes per commissioner as possible, so that we can, stay on target here with our schedule. And so the first one up is Commissioner McAllister. If you want to briefly go over your recommendations.
So I'm the new person. I'll be much less than 5 minutes. So I looked at what Leslie sent from the previous iteration of the commission and picked out, could you share again that document, Sandy? I think my recommendations and everyone else's was on that. And the first was the all-payer database. It seemed like that was a popular choice among the commission in the past. And I actually am confused of where that stands, if that's already in the works or we still need to codify it into law. So that one rose to the top for me. A second one, my instinct is to always represent the needs of the patients, but I always think that we do that by meeting the needs of the providers as well. And telehealth visits being paid at parity of in-person visits enables patients to access the level of care they need. I had a parent who was dealing with a devastating cancer diagnosis, and we physically could not get him to the oncologist. And so having those telehealth visits were vital. And if the provider wasn't being paid appropriately, they won't be motivated to allow those accommodations for patients. And the last one, I forget what 7 and 15 were, but when I was reading over those areas, what came to mind to me was, I know in California, they provide Medicaid to all children birth to 26, regardless of documentation and immigration status. And to me, it seemed to fit those areas. So that is what seemed important to me, but I'm very interested to hear from the other commissioners.
Okay, it looks like we have a question from Commissioner Tyler Garner, or she might still have her hand up from before.
I was just going to note that as everyone is sharing, it'd be helpful to have some context around the issue or problem it's designed to address and its potential impact for others, or I would find that helpful. Thank you.
Okay. And then I can update you on the all payer claims database. We did, the Patient Protection Commission did sponsor a bill last session, and it was successfully passed, SB 40. I'm happy to talk with you offline about all things all payer claims database. It's near and dear to my heart. So that one was one. We did also have a telehealth bill, but I'm not sure if it got to the parity piece. So we'll have to check on that for you.
It started out as a parity piece, and then it was changed by the legislature, and that's what will happen. I mean,
that's what I thought.
The legislature has the choice to, these are bills from us, but we don't legislate them. The legislature is going to legislate what they want. And so there were changes made to that bill as it went along. It does have some parity pieces in it, but I think it was changed pretty dramatically in the end. We better check on it. You're right. The final version.
And we can, Leslie can send links to that after the meeting, to both of those bills. Did we have any questions from any commissioners on these recommendations? I don't see any hands. Okay, the next one is mine. And I do plan on submitting more. This was just the first one that I thought of. And I think it's important that we codify the executive order so that we can continue the cost growth benchmark work. This is a long-term initiative. And so I think it's really important that we get that into statute. And I think that falls under our priority 3. Or not priority, but the item 3 on the template. So if anyone has any questions, it's pretty straightforward. Okay, Tyler, Commissioner Winkler has a long list, so hopefully you can talk fast.
Hello, everyone. I won't get into all the nitty gritty, but if so the first point there, I think one of my priorities would be addressing social determinants of health. So the big things there is our housing crisis throughout Nevada, and just trying to address that any way we can. If that means permitting municipalities to create rent control boards, if it means working through Medicaid state plan waivers to set up non-clinical services, different benefit packages, expanding Medicaid coverage to cover dental, use some of the things that we've been doing during the public health emergency and see what we can use there to retain people who were now covered. That's probably my number one priority. I think there's lots of different ways to address it. So I definitely want to talk about that some more. What I saw with a lot of the other commissioners that submitted something, and it's kind of approached a different way, but trying to find a way to cover more people, and specifically coverage for people regardless of their immigration status. I think there's lots of different ways to do that. California has done a few different things. Obviously, they have a lot more funding than the state of Nevada, but there are certain measures that can be done, requesting a waiver through Medicaid to set up a program, finding new funding mechanisms, getting private insurance to cover dependents of someone, regardless of their immigration status. And again, use some of the stuff we've learned during the public health emergency. And actually, I want to put a pin in that because I know there's a lot of issues that are going to come up with re-enrollment or having to check in with everyone re-enrolling in Medicaid, because basically for the past 2 years, we haven't been having to recertify everyone. And so we're probably coming to, I know that'll probably be a big issue soon of having to re-enroll everyone into Medicaid that have just been that have been covered for the past 2 years. I don't know if there's anything the board can do to help with that or address that, but that's definitely something we should keep an eye on. So that I won't go through everything, I think probably following up on all our transparency, affordability, accountability, the work of the PPC, I'd like to talk about that as other commissioners have discussed, codifying that and perhaps spelling out a little bit more what the PPC would do and review and what powers it would have. And I'd also be interested in expanding on NRS 439B 630, which created the drug transparency boards. If we could actually take that a step forward and have a drug price affordability review board like other states have done to identify high cost drugs and even get to the point of setting rates for those things. I'd also really like to get to a health plan review board, everything that could help protect our consumers. So those would be my 3 things I'd like to address.
So if I may, Dr. Khan, what we need to do to move the process forward is what I would request the commissioners is to focus on the subject matter specifically for prioritization. So once hopefully we narrow that down to top 3, then we can go into the discussion of those subjects in detail in the subsequent meetings to narrow down. But if we have a specific, concise subject matter that we want to discuss within the parameters of the legislative mandate, if I may call it, and the original governor's directive. So I think within that framework, if we can come up with the priority subjects, then we can go into the discussion at subsequent meetings to elaborate on that, what else that comes under that headline. So go ahead, who's next in line for an input?
Did anyone have any questions for Commissioner Winkler? Okay, it looks like Commissioner Roa Dugan is up next.
Yes, hello, good morning. Okay, so I had, I think 3 or 4 suggestions, and my top one would be increasing access, just like Commissioner McAllister and Commissioner Winkler mentioned. I said it in different words, but it means the same. Just having access to healthcare for everyone, regardless of immigration status or anything else. My second recommendation was to create something like the procedure price lookup tool that was created in the last presidency. So something like that, but for treatments and procedures, medical treatment and procedures. I looked at the tool and it only includes surgical procedures. So I think that this is a good example, but it would need to be expanded. The third suggestion was, I guess, in order to make this tool available, we would need the participation of all the healthcare facilities and hospitals. And I don't know about you, but I think that unless things are mandated, people don't tend to do them. So I guess we would have to ask them to provide those prices for the tool. And then the last one is again, increase the access for healthcare. And this is just another way, and it's kind of following the lead from California and expanding our Medicaid access to all immigrants 21 years old and younger. So the California one is 26 years old and younger, but I thought, okay, our budget is lower, so let's make it 21 years old and younger. So those are my suggestions.
Okay. Does anyone have any questions on those items? I don't see any hands. Okay, the next commissioner is Commissioner Bond.
Thank you. So my first issue is ensuring patients have access to control of their medical records and information. This is an HIT initiative, so it's really tied to, I think, the DHHS office and the HIT program. But it's also tied to the new role of the Patient Protection Commission, because the legislation that passed in the last session adds HIT to our purview. And I'm trying to figure out how we can best use that. And frankly, I think that the way that we're doing HIE in the state is not the future of the way HIT should work. So what I'd like the Patient Protection Commission to do is support initiatives that make the physician offices interoperable with each other, and the hospitals interoperable with all. And then create a patient process where the patients can get their records, because right now that's what's kind of missing in Nevada, and it's part of the Office of the National Coordinator and CMS and HHS federal requirements now that patients have access to their electronic information. And I think it's a great service to them to be able to get it to them. And then also that providers will be interoperable. So that's the sort of, I'm saying in too much detail because I'm very interested in, Sandy, you capturing this, because it's kind of like your world. So, but that's my top priority. Second would be, we are suffering in the state from increased consolidation of the hospitals and the healthcare market, of private equity coming in and buying a lot of the facilities and the practices. And I would like us to be able to prohibit some of that. But you can't, right? They can buy whatever they want. But there is a law on the books in Nevada about who can purchase and own physician practices. And it's gotten a little muddled in an AG opinion and in informal practice. So I would just like it clarified that the only groups that can purchase a physician group, or hire physicians themselves, is the nonprofit county health hospitals and academic institutions. That's the way the law was originally written, and it's gotten confused. So it's just a clarifying bill. The third bill I would like to see is, I think that was also on somebody else's list, codify the Patient Protection Commission, which I think was already raised. So that's just a duplication of somebody else's thoughts. The fourth one, and since we're only sponsoring 3, maybe this won't matter, but there's a bunch of charges that I think we should review that go into a bill for a patient that really are not providing actual care. And I think that we should see if there's things we can do to limit the ability to be charged for those, in a nutshell. And I can come back with more. Thank you.
Thank you. Does anyone have any questions for Commissioner Bond?
Can I say one more thing since I'm last? Do you mind? I'm not being formal enough here today. I think, Dr. Khan, what you just said, that we should establish the issue areas we want to work on first inside the 19 categories that we are responsible for. I think that is not as important this time around, because we're a little farther down the road in understanding the BDR process. I would suggest, if possible, could we consider that we just put the bill drafts together that we think are priorities, but make sure the mandate is that they have to they have to follow one of those 19. They have to fit into that group of 19, or they can't be considered by the commission. Is that a possibility? It would be easier.
Yeah, I think I have no problem with that. Just we need to get some clarity from our council for all of us that
Yeah.
that's doable
Thank
and we
you.
can do it. Then I have no problem with that.
Yeah, and we also might want to consider limiting the number of bills per commissioner just to help us with prioritizing.
Yeah. Okay.
Right.
But we can, we're not voting on anything today, so those are all good
Yeah,
thoughts.
I think it has been suggested if we have every commissioner give at least 3 of their top priorities. I mean, there's no hard and fast rule of 3, but at least that narrows things down, makes it easier to focus on something that we all really want done rather than, 6 and 5 and 7, and then we get nowhere really.
Right.
So we can move on. Who's next?
That was all that we received so far. If there are no more questions on the process or any more comments, I think we can close this item.
I would like to say something. Commissioner Khan had to step away, and Commissioner Grady did send her priorities 1, 2, and 3. If you would like the floor, Commissioner Grady, please speak up. And like we said, this is just a continuation of the conversation.
Good morning. This will be just really brief. My suggestions were 9, 3, and 4, and it was really looking at disparities, cost of healthcare, and improving accessibility to healthcare for all. That's it. Thank you.
Thank you. Any other thoughts, inputs before we move on?
This is Tyler Winkler. Can we just commit to a timeline then for getting all the other BDRs from the rest of the board members and a discussion time to kind of finalize where we're going to be moving forward?
Sandy, you want to comment on that?
We can shoot for next month's meeting. I think we're also, stretched fairly thin without an executive director at the moment. So that's kind of the struggle that we're faced with, because that role really does play a big role in this process. So we appreciate your patience while we struggle through that. But we can shoot for next meeting and see how it goes.
Sandy, it's Michael. I think our meeting plan calls for us to come back to this in May.
Okay.
Because I'm pretty sure, because I think we're going to focus primarily on the data presentations.
Okay, in April. Okay.
And also in April, we will be discussing the bylaw amendments too. Just to keep that on your radar.
Yeah, that may be a little time consuming also.
Okay, so it sounds like we're going to shoot for May's meeting to have another discussion, but certainly in the interim, if everyone can get their information to Leslie, we can get it organized and work on that in the interim.
Yeah, I would appeal to every commissioner if we can expeditiously forward the information, because as they said, we don't have an executive director. So to put things together takes time with the staff situation. All right. Any other thoughts before we move to the next item? So that's that one. The next item we have is for item number 5. For possible action is they discuss and make recommendations for the process of identifying and prioritizing cost growth mitigation strategies. So this is to Michael Bailiff on this one, so we can proceed with that, Michael.
Thank you, Chair. Again, everyone. So in follow-up to the conversation we're just having, here is what we've got planned for our next few meetings. So in April, we're going to have an introduction to the data use strategy, which is mining claim data to get insight into what's driving performance against the cost growth benchmark. And we're going to review findings of Medicaid and PEB phase 1 cost driver analyses. We're also going to revisit provider entity population thresholds for submission and public reporting of provider entity level performance. And then finally, as Leslie just indicated, we're going to look at bylaw changes. So in May, we're going to come back and talk about the 3 bill draft requests in greater detail and at greater length. And we're also going to have a first conversation about potential cost growth mitigation strategies to ensure that that we are all successful in achieving benchmark level spending growth. And we've not talked about this before. And then in June, we'll talk about bill draft again. And at your request, we'll have a conversation about quality. You express interest in reviewing quality benchmarks in other states and to look at opportunities for improvement in quality in Nevada. And so that's what we've got planned for the next 3 meetings. We don't have July and August scoped out yet, but we've got a rough plan for April, May, and June. Okay, so hopefully that helps you understand where we hope to go in the coming months. Okay, so for this part of the agenda, there are 3 separate topics I want to touch upon. The first is I want to share with you what the advisory subcommittee had to say about your discussion of transparency and accountability, which was something you explored at our last meeting. 2, I want to introduce the definition of a process for identifying and then prioritizing cost growth mitigation strategies. So before we get into talking about strategies, we want to have a process for doing so. And then I want to ask you to revisit a policy recommendation that was made many, many months ago, when in fact, some of you weren't even on the commission, having to do with inclusion of spending related to out-of-state residents. So first, advisory subcommittee. So we shared with them your discussion at the last meeting. With regard to transparency, you all agreed that payer and provider entity actual rate of cost growth should be publicly reported and that there should be annual hearings held to the extent that state has the capacity to do so. The advisory subcommittee didn't disagree with either of these recommendations. They did say they thought it was important for payers and providers to be able to review and validate data before it's publicly reported. I shared with them that doing so is standard practice in all the other cost growth benchmark states. That is, they get to see the data before it's made available to the public. And if they have any concerns about the validity of the data, they can raise those concerns and have them addressed. In addition, there were a couple of members who thought that if there are public hearings, that payer and provider entities should be able to participate in dialogue to help explain reported findings, and specifically to provide context for why performance looked the way that it did. Any questions or reactions on these comments?
I have a quick comment here. It's not a comment for the record. Regarding the concerned parties wanting to have the access to the data before it's published, if there is a concern expressed about their data and they are given whatever information is available as to how they came to that determination, if there's a disagreement between the 2 sides regarding how the data was derived, etc., what happens?
So the experience that I've had thus far is I haven't seen this happen a lot. There was one case in which there was a voicing of concern about the results, and it led to the state actually making some changes to its methodology, which actually we incorporated into our presentation to you, and which you adopted. And in that one case, the state did not report the data that year because it found that the concerns voiced by the providers and payers were legitimate. And so it didn't report the data and waited a year before making the data transparent. That's the only time I've experienced this to date.
I think that's good to know, because it's important if the payers and providers have any legitimate concerns or questions, either the data not be published or at least addressed in a timely manner in that context.
Yes, I certainly agree. Anybody else? Okay, so Tyler?
Sorry about that. When I was watching the subcommittee meeting, I noticed at the end, one of the requests was that they would want the data that we're putting together to be reported to the subcommittee before the PPC receives that data. And is my understanding that they were going to receive it, and I don't know how comfortable I feel with that.
No, it wasn't. They were not talking about the benchmark performance data, Tyler. They were talking about other analyses.
Which other analyses then?
For example, at our next meeting, we're going to be sharing some analyses of cost drivers based on.
Can barely hear you. Could you speak into the microphone, please, Michael?
Sure. Tyler, they were referencing analyses that are going to be presented at the next meeting of the PPC, which will look at what's driving healthcare spending growth in Medicaid and PEP. So that's not performance against the benchmark. In fact, we haven't even gone out to collect data yet for the benchmark.
So sorry, just to be certain, that the subcommittee is not going to receive information before we receive the information, correct?
Not on benchmark performance, correct.
Okay, but the other analysis they are?
So in general, the subcommittee felt that it would be more effective for them to review content and create their recommendations for you to hear when you discuss a topic, as opposed for you to discuss a topic and then for them to react.
Okay, I think any decision about that should probably go to the PPC first, as they are the subcommittee of this board.
Okay, so we can certainly open this up for discussion. I think Sarah had made, tell me if I'm wrong, Leslie or Sandy, but I think Sarah made a commitment to flip the ordering as it's done in Washington State, where the advisory committees see the content, give their input, and then that's relayed. If you all think that you should see things first and they should be responding, weigh in and say that.
A quick question, if I may. Once they submit it to the PPC first, that's public information. So are they able to challenge it after it's made public and then go back and say, no, we don't agree or disagree, etc.? So it's already been made public before they've had a chance to give their input, or would they give their input before it comes to PPC?
So it can be done either way. In other states, I've seen it work both ways, where it goes to the primary advisory body first and then to the secondary advisory body second. In Washington, it goes to the second advisory body first and then to the primary advisory body. You can do either way. I don't know, to be honest, that there's an absolute right or wrong here. But so if you see it first and it's public, they can still comment on it. Leanne and Babette? I'm sorry. Leanne and Babette.
So that was my question. The information that you're talking about presenting to the advisory committee first gets presented in that public forum. It's not that it's getting presented outside of public view. Is that correct?
Right.
Okay, then that's fine.
Babette?
For me.
That was my question too, the same one as Commissioner McAllister. I couldn't tell with the comments about public. It seems like both venues are public, so it's going to happen. There's going to be public eyes either way. So I'm just making sure I understand. Thanks.
Sandy?
Yeah, I was just going to say that I think the order was based on the advisory committee, subcommittee advising the PPC. And so it seemed logical for them to create an, advisory opinion and report it back to us instead of the other way around. So I think I might have been the one that made that suggestion. So I'll take responsibility off of you. And if a change needs to be made, I guess we can talk about that. But no decisions are made by the advisory subcommittee. They just advise us, and they're a panel of experts in their field. And so I personally would like their opinion on something before it's, when it's presented to the PPC.
Yeah, I think I agree with those sentiments in general. I was more concerned that it feels like there's executive decisions being made without the board. And I just want to make sure that we're a part of that process and where that authority is coming from.
Just Michael, your sound does go in and out, and it's very hard for me to hear you. I don't know about the other commissioners, just to be aware of that.
Okay, I'm not sure why that's happening. I've never had that experience. Thank you for letting me know. I will raise my voice. Hopefully that will help. All right, so Tyler, it sounds like you're okay with things starting with the advisory subcommittee and then coming here.
Yes, that's fine.
Okay.
I wanted to know about.
Yeah, okay. All right, so that obviously did not happen in this case. So what you're seeing is the advisory subcommittee responding to your last meeting here. Okay, so the second topic that we discussed was you had interest in talking about quality benchmarks and quality strategies to complement the cost growth benchmark at a future meeting. And as I just indicated, we've got this scheduled now for June. You also want to review performance on quality relative to other states. The advisory subcommittee, again, did not disagree with this recommendation. When they learned about what Oregon does, though, to assess performance against the benchmark, one of the members recommended that the state establish explicit parameters for what constitutes reasonable cause for exceeding the cost growth benchmark. As a reminder, Oregon has accountability implications for exceeding the cost growth benchmark in a way that Nevada does not. So if you exceed the cost growth benchmark in Oregon and there's not reasonable cause for you doing so, then you have to submit a performance improvement plan. And then if you exceed it 3 out of 5 years, you can be fined for some amount of money. That does not apply in Nevada, but nonetheless, one of the members, and I think with support from a second one, asked that the state establish parameters for assessing when it's reasonable to exceed the cost growth benchmark. Anybody want to respond to that thought? Babette?
Thank you. If it's one member and then another member joins in, but then we got to talk about process again for a second for my benefit, is that not voted on by the advisory group? It can just be one person that makes recommendations and sends it to us?
Yep.
Oh, I think that that's kind of an issue. I think if there's not a majority in the advisory committee that agrees with something, it probably shouldn't be considered a suggestion, really, but maybe that's a future meeting as well. Because that could be anybody saying anything, and then it makes its way to us without any consensus from the advisory committee. So how would we get advisory committee consensus?
Yeah, so to date, we have not sought advisory committee consensus. It's a disparate group, and we've just asked them to weigh in, and we then convey to you what the voices say. And sometimes it's a couple people, and sometimes it might be more. It's not as if they've had so much to say that we've had to do a winnowing process.
Okay.
Sandy, do you want to comment on that process?
Yeah, I was just going to say in prior presentations, Michael has provided the number of committee members on the advisory committee that had certain recommendations, so we could see, you know, if it was just one or if it was
Right.
most. So that information I thought was helpful, and I don't know if it's helpful to this, but.
Well, I think it would be helpful because otherwise we're assuming that either the rest don't care or the rest could be opposed to it. But I guess if they were opposed to it, Michael, you would have said that to us as well, right? So, okay.
Nobody opposed this idea. The person who first voiced it, not surprisingly, represented organizations that are going to be publicly reported upon. Okay, there are a bunch of members of the advisory subcommittee who are not going to be subject to public reporting, and so they're going to tend not to weigh in as much because it doesn't impact them. So you know, you're going to hear from certain people who have certain perspectives and interests on individual issues. But as Sandy said, in this particular case, it was a couple of people and nobody opposed it. And I presented just to you, not even, it's not a recommendation. It's just conveying to you, here's a sentiment that was shared. You all can look at it and say, we don't agree, let's move on. Or you can say, wow, that's a great point. We hadn't thought about that. Yes, we should make a recommendation here.
Okay, so can I follow up? Yeah. I would say if we don't have significant support from the committee for a position, then I think that we shouldn't support it till we know more. I think creating reasonable cause is going to take us a long time. So I'm not sure we need it this round. Maybe it's on some future timeline. I'm not sure if I totally feel 100% that way, but I don't know how to calculate what an appropriate reasonable cause would be. And is that a reg, or does that become a statute, or like, is that our job? Whose job is that? It seems like a lot.
Tyler, you want to add your thoughts?
Yeah, just on that same point, I think that's really putting the cart before the horse. We're not at a place to say what would be reasonable cause. We're just reporting, this is our cost growth benchmark. This is the data we received. I understand the concern of this is public data, and it could look bad if spending is higher, but at the same time, we really don't have the criteria yet to be able to determine what would count as reasonable cause or not. And I think as we work together more and this becomes more common, we'll be able to understand what are the cost drivers and what do we feel are appropriate justifications for going over the cost growth benchmark.
Okay, I mean, so we're quite a ways from doing public reporting where individual organizations are going to be named. So my suggestion is when we get a lot closer, I mean, we're 2 years away from it before it's going to be reported, naming names, that my suggestion is that you all revisit this at this time, because it will be relevant then, because there are going to be organizations that are going to be sensitive to being called out for being above the benchmark if there is, in their eyes, a legitimate reason that they exceeded the benchmark. Okay, but because it's 2 years away, I think it's reasonable to defer on this for now. Okay, so that was their feedback. I want to transition now to talking about cost growth mitigation strategies. So these are strategies that you would recommend be pursued in order to slow healthcare spending growth. The strategies could take any number of forms. It could be multilateral action, unilateral action, and because of your BDR opportunity, it could be legislative action. So you could recommend a bill, and in fact, some of you made some suggestions that would constitute cost growth mitigation strategies. Right? So what I want to put forth today is a suggestion to define the process for identifying and prioritizing them, because over time you are going to have a number of ideas and you won't be able to, and the state won't be able to pursue all of them. And so they're going to have to be prioritized. And so I'm suggesting a process for doing all of this before you begin to actively discuss cost growth mitigation strategies. Does that make sense? Everyone following me? Okay. So as I just indicated, it's unlikely that that involved stakeholders are going to have resources to pursue every single possible strategy to address cost growth. And so we're trying to establish a systemic basis for doing this. So I want to share with you straw model criteria for prioritizing cost growth mitigation strategies. I'm borrowing these from 2 other states that have already identified such criteria. So these, I didn't just create these out of whole cloth, but there are 2 states that have either these literally or a variation of them. So 4 criteria, I think. The first one is that there's spending data that indicates there's a significant opportunity for either reducing spending altogether or spending growth. And a significant opportunity could be because spending growth's been really high in excess of the cost growth target in the service category. There's a lot of variation in spending across geographies, payers, or providers. Or spending or utilization of services is in excess of external benchmarks. So for example, we look at utilization or spending relative to other states, we find that Nevada is a high-end outlier, right? So all of these would be ways that data could be used to identify a significant opportunity. Okay, this is just number 1, but before I go on to the others, any questions or reactions to this one? Seems reasonable? Okay. Number 2 is implementing a strategy is likely to have substantive impact on cost growth target or cost growth benchmark attainment. The state that uses this uses the word target. So substantive impact means there would be a measurable reduction in per capita cost growth at the market or state level. So it wouldn't be a 0.001% impact on trend, for example. If there is no evidence of substantive impact, there's a compelling logic model for the strategy that leads one to think, we really, really think that this would have a meaningful impact on benchmark attainment. Leanne?
The only question I'd have, because the word significant and substantive can be interpreted, is can it be to sections of the population and not the whole population? So I think about the impact of Medicaid churn on children, right? That's only children. That's only a quarter to a third of the population. So it's significant for that population, but maybe not for the whole state.
Yeah, so this is all relative to the benchmark. So probably, first of all, children don't drive a lot of spending towards the benchmark. So probably anything having to do with children, while it might meet another important public population health aim, it's probably not going to impact the benchmark. So I would just say all of this is in light of, is it going to influence performance against the benchmark?
So this is very macro.
Very macro. It could be different though for Medicaid and commercial, right? So it might have more impact on one market than on the other.
Okay, thank you.
Yeah, but it's macro. We're talking about having, impact at a real high level, which is a tough test to meet. Babette?
So that's causing me concern, and maybe we don't have time today, and I actually have to leave this meeting, but I'm really interested in what you just said. So if you think about a facility, and a facility opens even though children are a small piece of the pie, that's a children's facility, and it's increases the price of what children's care costs 200%. It's still a small piece of the pie, but it's a huge increase in the cost of that quadrant. So how would we understand that? What would we be doing in this project that we're building? Would we just ignore that that's happening, that there's a out of control trend in a group, even though it's a group that's not significant to the big pie?
So these are intended to be serve as guidance and decision rules. They don't lock you into anything. You might find an example of a strategy that doesn't perfectly match up against these criteria, but for other reasons, you might say this is really important. This is just to find a way to, imagining that you're presented with 10 strategies and you really can't move 10 at once. How do you begin to whittle them down? That's what these are intended to do.
Okay, then this goes back to an earlier meeting where I'm like, okay, if we're not going to do it for this, but we also don't want to lose the data. We're not going to capture the data in this piece, but we're going to have the data somewhere. It's kind of like that because there will be future work. And the whole reason for this project is to start having some transparency on how much things cost and how much they increase.
Yep.
So I want to make sure whatever decisions we make about what matters to the growth benchmark, that we still have the data for further evaluation and projects in some world where we're going to have more time to look at per population issues.
Yeah, so the data use strategy exists separately and in support of this. So,
Okay.
We're developing all these standardized analyses that are going to bring you data. And then looking at the data, you're going to say, wow, we see a huge opportunity here. So what are strategies that we might want to pursue? That doesn't mean you throw away all the data that you've looked at, but there's certain things that are going to pop out at you. You're going to say, we better focus here.
Yeah, but if you're asking us now to say what we care about, then we're taking away the layer where we get to say we want to focus here. We won't see it. I'm afraid we won't see it anymore.
No, you will. You'll see all the data. And then after you see the data, you will then have the purview to say, well, based on what we've seen, where do we think we need to act? And then how do we prioritize where we act? This is intended to help you through the prioritization exercise after you've seen all the data. Does that help? Does that reassure you a little bit?
No, I feel like we're slightly going in a circle, but I also feel like I'm not, it's not my key issue today and I'm slowing us down, but I do want to make sure we don't decide on a very narrow scope and because of that, never get to the analysis of the bigger picture. So I can't tell if you're saying yes or no when I ask that, and I can't tell if I'm asking it very well.
So yeah, this in no way limits the analyses that are going to be performed or that you're going to see.
All right.
It just allows that the analyses are intended to inform action. And this is to help you decide where do you want to prioritize action as a step that follows the data analysis, which is much broader. Tiffany?
Okay.
Tiffany, we can't hear you yet. You're muted.
Are you able to hear me now? Yes.
Why don't the rest of us mute and maybe we'll hear Tiffany without an echo.
Are you able to hear me now?
And Tiffany, do you have a cell phone or something near your computer?
I think you need to hang up on your cell phone, Tiffany, and just be on the computer. Or you can type your question in the chat. We can certainly do that as well.
Now, why don't you try the chat, Tiffany? Okay, so hopefully Tiffany will be able to do that and we'll respond. So let me show you the last two. So number 3 is the strategy is actionable. And so there's an opportunity, but we actually put something into action to have impact. And then finally, the stakeholders who would have to take action have both capability and capacity to design and execute and to do so well. Right. So the idea is if you had a set of strategies that you were contemplating, you would line them up against these 4 criteria to see if it would help you whittle down your list. Anybody want to respond to this idea of using 4 criteria such as these or modified version of these to help you prioritize? No reaction? Tyler, I can always count on you for a reaction.
Of course. So maybe I'll have to bring this up as like a standing agenda item, but I feel like some of the frustration and questions that Commissioner Bond was bringing up was related to there's some serious consideration of data and decisions that need to be made regarding specifically cost mitigation strategies and just the cost growth benchmark generally, and it's pushing up against some of our other duties, and maybe it would make a lot more sense to support another working group of our members that focuses on making these decisions. But for just these options here, I definitely think that these are excellent strategies just to help develop things that we can target and that would be attainable.
Okay, thanks. Anyone else? Okay, thank you. All right, so I think I asked this question. Any other writing criteria that we're missing here? Tyler?
I think perhaps we're not ready to commit to some strategies to prioritizing cost growth mitigation strategies. I think we'd like to know more what we're looking at before.
Okay, so in April, you're going to see data, and in May, we're going to talk about potential strategies for the first time. You can then revisit these criteria when you start to put them into use. And if you want to modify them, you can modify them. But it's at least a starting point for you. Leanne?
And when the data is presented, you or someone will be on hand to answer our questions so that as we're evaluating the data and applying that strategy, we don't feel kind of overwhelmed or lost by its meaning.
Yeah, I think you should always get help understanding the data that's being presented. And it's not going to be a one-time presentation of data. You're going to get waves of it over time. And but you will probably want some help making sense of it. And I think it's probably the obligation of the state to provide you with that help. And there will be people who will have worked on the analyses that will have both data analytic expertise, and then there'll need to be people that have sort of health policy expertise.
Yes, and I don't know if this impacts our strategy for prioritizing, but to build time into that too, so that when data is presented, we're all given time in between the presentation and a decision-making to absorb it and think about it and consider different points.
Mm-hmm. Yeah, makes sense. Sandy?
I just wanted to say that I agree with the proposed criteria in that it can be changed. It's not like we're locked in, and we have to start somewhere in order to prioritize. We can't just look at all the data. We have to focus to make progress. And so for those reasons, I support the proposed criteria.
Thank you, Sandy. Okay, the third and last topic I want to bring to you today is a recommendation that was made last spring, maybe, on which populations are included when we're calculating performance against the cost growth benchmark. So yeah, it was last April. The commission recommended that benchmark performance be assessed for state residents, whether they're receiving care in state or out of state, and out of state residents receiving care in state. The advisory subcommittee last summer opposed the recommendation to include spending for out of state residents. We never discussed that feedback over the summer because the PPC was temporarily disbanded. But that was their feedback last summer, was to exclude out-of-state residents. So I'd like to ask you to reconsider your prior recommendation for a few reasons. First, every other cost growth benchmark state excludes non-state resident spending from their healthcare spending calculation. Two, I'm not sure that it makes sense to include spending for non-state residents when measuring state healthcare spending. Further, I'm not sure it's even feasible because the way that we calculate spending is to get payers to submit their data to the state. And non-state residents are often going to be covered by payers that are not licensed in the state of Nevada. In fact, when we talked about this the first time, I think I mentioned somebody's visiting from Alabama and they're covered by Blue Cross Blue Shield of Alabama. We're not going to get data from Blue Cross Blue Shield of Alabama. Then finally, the governor's executive order from December seems to suggest the focus of the cost growth benchmark should be on state residents. It uses the term all Nevada populations. So for all of these reasons, I want to suggest that you reconsider the recommendation. And I'm raising this today because we are pretty far along developing an implementation manual that will give guidance to payers on how to submit data for a baseline measurement of cost growth in the state. And this is a key parameter to be conveyed to the payers. Sandy, I'm not sure if your hand is up anew or from before.
Sorry, that was from before, but I'll go ahead and say that I agree with the recommendation to exclude. Revisited recommendation, I guess.
Okay, Yarlene?
Yes, I also, now looking at it this way, I don't know, it makes sense what you say, to exclude out-of-state residents getting care in Nevada. Are we going to vote on this change?
So I think our current bylaws say that you all make decisions by consensus unless someone calls for a vote. So let's see first if you've got consensus. Tyler?
Sorry, I don't, is there anyone else who'd like to make a comment? Because I think I might spend some time on this.
There are no other hands up right now.
All right, so I'm a little frustrated that this is being brought to us now. And it kind of opens the possibility that why don't we just go over every part of the previous recommendations and reevaluate them as a new board? If that was the case, then I would like to design a cost growth benchmark that tried to collect as much data as possible, including uninsured and all the things that people would think about when they talk about healthcare spending. If the issue is it's just not feasible, we can't do it, then that's a completely different matter than saying we want to collect all healthcare spending in the state of Nevada. I also think it'd be a disservice to the prior board to cherry pick things that we would want to throw away. Those are my initial thoughts on that.
All right, so you would like to keep the inclusion of non-state residents. Is that what you're saying?
Unless we can then completely review all further recommendations.
Okay, all right, so you oppose unless we revisit everything. Got it.
Correct.
Anybody else want to weigh in?
This is Dr. Khan for the record. In my view, the previous commission, as you recall, spent a lot of time on all this with a lot of input, etc., on this whole subject. To restart from scratch would be a major undertaking, while we have many other areas also. The bylaws is just one small piece of it, but the other priorities, and then preparing the bill drafts in a timely manner for our next session. So I would like to hear from the commissioners. Do we start all over again, or bulk of it all over again, or see what items that need to be revisited, if at all?
Thank you, Chair Khan. Sandy, then Leanne, then Tiffany.
So I just want to reiterate that it sounds like it's not feasible for this particular item, which is, I assume, why you're raising it to us again to revisit. And I would also like to add that, this program and the technical assistance being provided is time limited. So I don't see how we could go back to the beginning and revisit everything. We've got to continue on the path, or we're going to run out of time. So I just wanted to note that.
Leanne?
I support only focusing on in-state residents and removing out-of-state residents. And I support doing that without having to revisit all the work done prior to my being added to the commission.
Thanks, Leanne. Tiffany?
I'm sorry, I'm hoping you can hear me now.
Yes.
Just two clarifying questions. As it relates to this issue, are there instances where, because we have tourism as a significant driver, there are healthcare costs that happen here that are individuals that are really out-of-state residents? So someone is here visiting the Strip and goes to the emergency room. Is that what that element was designed to capture, those kinds of costs? Were they trying to account for
Yes,
the fact that there may be a significant percentage of those kinds of instances? And so that if we're talking about healthcare costs within this system, it includes individuals that are visiting here from other places?
Right. So those represent costs, but they don't represent Nevada spending, because the spending isn't being made by Nevadans or Nevada employers. The spending is being made, by people who are from outside of the state. But you're right. That's what the thinking was initially, was that there are a lot of services delivered to non-residents who are tourists.
Thank you for that. And then just one other clarifying question, and this goes back to the other slide. If I was understanding you conceptually, essentially you were just saying, as we decide on a cost mitigation strategy, that there should be at least some consideration for, is there an opportunity? Is it actionable? And will it have an impact, right? That's all you were suggesting to us?
Mm-hmm.
And so from that perspective, just know that I support that previous criteria as well, because those seem consistent with things like SMART goals. Like, is it measurable? Is it attainable?
Yeah.
Is it, that kind of thing? And so I don't know why we would be opposed to asking ourselves, is there an opportunity to do it, and is it actionable as a part of considering whatever the strategies will be? Okay, I'll be quiet now and try to figure out these technical issues on my end. Sorry.
No need to apologize.
This is Dr. If I make a quick comment.
Yes.
Out-of-state people who come to Nevada, whether it's tourists or otherwise, a fairly large majority of them have insurances from their own states. And so that cost goes to those insurances who are based out of state, whether it's from Washington State or New Mexico or what have you. So that is, like you said earlier, Mike, it's not a cost to our state or our payouts. Number two, there is a small percentage that arrive here with no insurance from out of state. They receive services in the local hospitals, through the emergency room, etc. But those are sort of non-collectibles for the providers. They have no insurance. There's nothing to collect from them, but they have received service. That is a small percentage. But otherwise, everybody who comes here has insurance from their respective states.
Thank you for the clarity. I appreciate the context. Are there instances where we have significant non-collectibles? And if so, will we try to account for that, or we see it as negligible?
Well, I don't know the numbers, to be honest, but Mike, if you have any thoughts on that. I know in our state, a fairly good number of population, from my experience, that come from California have the California Medicaid, and you try and collect something from California Medicaid, it may take a year if you're lucky, and they pay in pennies to the providers when and if they do pay. So that part I do know, that even though they have California Medicaid, very difficult to collect. And there's a fairly good number from California that come here.
I think that you might consider if we should be subsidizing healthcare costs for California in that way. And know that I don't necessarily, because I am not an expert in this area, landing strongly on one position or the other, but I can see the rationale for trying to account for those types of costs while hearing that it may be difficult to account for them.
Yeah, it would be difficult because you would have to get California Medicaid or California Medicaid health plans to report spending data to the state of Nevada. And they would probably say, fat chance. It just wouldn't happen. So anybody else want to weigh in? So I think we've heard from some of you, but not from all of you. From those of you who've been expressed an opinion, you've supported the idea of excluding non-state resident spending, except for Tyler, because the bylaws say decisions shall be made by consensus, except when someone calls for a vote. It sounds like there is, at least from those who have spoken, there's a majority who support it. But if consensus is everyone agreeing, then you don't have it. Which
Mike want us to take a vote then so we can move forward.
Yeah, I think we should.
If it's possible, then I withdraw my issues with, and I would say just exclude out-of-state residents if that
Okay.
gets us there.
Okay. All right. Thanks, Tyler.
So
All right.
is there anybody else opposed so that we can consider a consensus? If we don't hear any other opposed, then Mike, you have it as consensus.
Great. Thank you. All right. So we will incorporate this into the implementation manual, which provides instructions for the payers, and which also will walk through for state staff what they need to do when the data come in. All right. So those were the three topics. I just want to let you know what's happening next. I know it's hard to keep track of all of this. So here's where we are in the benchmark analysis. By the end of June, we're going to issue a formal baseline data request to insurers for a time period to be defined, but certainly before 1/1/22, to look at what spending growth was looking like before the benchmark was established. And there will be a benchmark implementation manual distributed to insurers, and trainings will be held with payers to explain all this to them. So all this is going to happen with a deadline of June 30th. The payers will be asked to submit their baseline benchmark data by the end of August. And then sometime in the winter of next year, we'll have reporting on performance against the benchmark using this baseline data. All right, so this is one timeline. In terms of looking at cost drivers as part of what I've called the data use strategy, in March, you're going to have a presentation on Medicaid and PEB cost driver analysis, phase 1. There'll be a phase 2 that will follow, but phase 1 will be at the March meeting. There will be then some public release of that information, and we'll share it with the advisory subcommittee and other stakeholders for their input. And then there'll be an update to the phase 1 analysis with 2021 data in the second half of the year. In terms of policy initiatives or cost growth mitigation strategies and policy initiatives, by May, you're going to decide on what 3 bills you want to advance for the 2023 legislative session. And in July, you're going to vote on what you want them to be and discuss pre-filing requirements in October. Okay, and as Sandy indicated, you just put your toes in the water on this topic today, but we got the ball rolling for further discussion. So any questions about activities in these three realms? Benchmark, doing the data analysis of cost drivers, or policy initiatives? All right. Then that's all I have.
Thank you very much, Mike. Appreciate it. I think we are coming along well today with our timeline. So the next item on the agenda is item number 6 for public comment. Leslie, do you see anybody north or south or anybody submitted written comments earlier?
No, Chair
Anybody?
Khan, I don't see anybody with any public comment.
And
But I
nobody
want to-
submitted?
I do want
nobody-
to remind people that if they did have a public comment, they can always submit it to us via email as well. But we do not have anyone on the line that is raising their hand.
Okay, I see Mason joined in. Mason, did you miss some of our discussion?
No, Chair Khan, sure didn't. I did, I don't want to drag out the meeting any longer than when we're wrapping up, but I did have my BDR submissions that Leslie's got. So thank you, Leslie. And they were just around telemedicine, healthcare interoperability, and network adequacy. So they are submitted and again, align with many of what individuals had mentioned. So, but thank you, Chair Khan.
No problem. So before we go to the item number 7, any other comments so far from anybody? If not, we go to item number 7, which is discussion of future potential agenda items. Leslie, I've had some input, some from people, commissioners. Do you have any of their thoughts that were submitted?
Nobody has submitted anything to me except for Tyler. Tyler, would you like to add anything?
So it
Which
seems like we're going to be very busy, especially next month, but I think maybe just the main thing I'd like to suggest is to have standing agenda items concerning our statutorily created duties, specifically data use strategies for access and quality improvements using data. So I think that's probably something we should always have on the agenda to be able to check into patient access to records and interoperability of medical records. And yes, I guess that would be the biggest things that I feel like we haven't been able to touch on since this board is formed.
How much time
Any
do you
other-
think?
Go ahead,
Sorry,
any other
Chair.
suggestions?
I'm just wanting to know, how much time do you think you would like to spend on this? Because we kind of need to know going in when we're planning an agenda. So we make sure that we can get everything covered. What is your suggestion, Tyler?
I'm not sure, because I feel like the next few months are going to be really dedicated to looking through and analyzing all the data we're going to get in April. So we might have to come back to that, or perhaps it'd be better to submit written potential agenda items past that. I don't want to commit to a time when there's still a lot to be done and a lot of information we're going to be getting next month. And we still want to discuss the bylaws.
Okay, so if I hear you correctly, Tyler, this should be on the agenda at some point down the road after the other two, the BDR aspects, the bylaws aspects are addressed.
Yes, I think so.
Okay, so we can put a bookmark on this, Leslie, so that we have it on file. And all right, any other comments or thoughts from anybody else? This is pretty strong silence. So I would take that as no further input for future agenda items. So I think if there's no other new business anybody wants to add, we'll consider the meeting adjourned. And I really want to thank everybody for being efficient in the time utilization, because I know everybody's busy and need to do their day jobs. Thank you very much, everybody.
Thank you, everybody.
Thank you.